Hello friends, today in this video we are going to talk about hypernatremia. Correction of hypernatremic dehydration is one of the most difficult things to do for a pediatric resident, mainly because it involves a lot of difficult to understand concepts and then many hard formulas to remember. But today I am going to tell you methods where you will not only get your concepts right, but also there will be no need to remember even a single formula. So, for the sake of convenience, I have divided this presentation into two parts. In part 1, we will discuss the important concepts like what is free water deficit, what is solute fluid deficit, whether we should give slow correction or a rapid correction, over how much time we should do correction. In part 2, we will do the actual mathematical calculations. But remember, there will be shortcuts so that don't have to remember any formulas. So friends, if you think you are already having a fair idea about the basics of hypernatremia, then you can directly skip to part 2. So let's begin. Okay, so whenever we deal with a dehydrated child, it means a child who has lost certain amount of fluid from his body. Now, what kind of fluid is lost is very important because that will determine the nature of dehydration. So, we have to analyze this fluid carefully, like what is the composition of this fluid which is being lost. So, if the fluid lost is isonatremic, then the patient will go into isonatremic dehydration. However, if the fluid loss is hypertonic, then the patient will go into hyponatremic dehydration. And lastly, if the patient is losing hypotonic fluid, then the patient will go into hypernatremic dehydration. This hypernatremic dehydration could be because of diarrhea, vomiting, excessive sweating, or even polyuria. But the cause is not important. What is important is that the patient has lost more water than sodium. Or in the other words, we can say that the patient has lost more free water. Of course, this patient has lost some solute also, but it is always more water than solute in a case of hypernatremic dehydration. So, for convenience purpose, we can divide the total fluid loss in a hypernatremic patient into free water deficit and solute fluid deficit. Free water deficit where only the water is being lost without any electrolytes in it, and the solute fluid deficit where water and solute both are lost. It is the free water which makes all the difference in the case of hypernatremic dehydration, and this is the part which is being given slowly when you correct hypernatremia. So we are done with the part 1. Now we understand what exactly is meant by free water deficit and what is meant by solute fluid deficit. In the part 2, when you start actual correction of the dehydration, you need to answer only these 3 questions. What fluid to give, how much to give, and over how much time we need to give. So how do we decide that how much fluid to be given to a patient? And a very simple answer to this question is that exactly the same amount which the patient has lost, right? Now how do we know how much volume the patient has lost? So it can be estimated either by your clinical assessment or, if available, the pre-illness weight. But this pre-illness weight is seldom known to us in our clinical practice, and we mainly rely on the clinical signs of dehydration. So you look at your clinical signs of dehydration and then you make a rough estimate of how much fluid the patient has clinically lost, right? So the patient, whatever amount of fluid the patient has lost, we call it total fluid deficit. I already told you that it can be divided into free water deficit and solute fluid deficit in a case of hypernatremic dehydration. So based on your clinical judgment, you make a rough estimate that it can be either 5%, 10% or 15% or mild, moderate, severe dehydration, right? So the total fluid deficit is free water deficit plus solute fluid deficit. So free water deficit Don't remember any formula. The first three letters of these three words itself tells you the formula. So free water deficit is nothing but the product of 4 multiplied by weight multiplied by deficit. By deficit here we mean the amount of sodium you want to correct, right? So it is the actual sodium minus the desired sodium. And then you get easily calculate solute fluid deficit by subtracting free water deficit from the total fluid deficit, right? So suppose a patient is having a total fluid loss of 1000 ml and you get your free water deficit by the above formula to be 600 ml, then your solute fluid deficit will automatically be 400 ml. So easy. Now what kind of fluid is to be given? So free water deficit we know that it is just plain or distilled water without any electrolytes in it. So it is just distilled water. It is a solute fluid deficit which contains some amount of sodium in it. But the question is that how much sodium, right? So if you have 400 ml of your solute fluid deficit and you need to add salt into it, just remember to add 1 decimal before the last digit, right? And that will be the sodium you need to add into your solute fluid deficit. That's it. So now you know your free water deficit, your solute fluid deficit, and also how much amount of sodium you need to add in your solute fluid deficit. The last question is over how much time we should give. So friends, in hypernatremic dehydration, correction is always slow. The rate of sodium fall should never be more than 10 to 12 milliequivalents per liter in 24 hours, right? So if you have a sodium ranging between 150 to 159, you can correct it over 24 hours. But if you have a sodium levels 160 to 169 milliequivalent per liter, then you need to correct it over 48 hours. Sodium levels ranging from 170 to 179 need to be corrected over 72 hours, and sodium levels of more than 180 needs to be corrected over 96 hours, and so on. So let us understand this with the help of this example. A 10 kg child presents to you with a history of loose motion for 3 days. On examination, he appears to be 10% dehydrated with a serum sodium of 160 milliequivalent per liter. Now you have to determine the fluid schedule for this child. So we already know the weight of this child. Our clinical assessment tells that this child is 10% dehydrated. The total deficit come out to be 1000 ml. And our lab report suggests that this child is also hypernatremic, right? So free water deficit, we can easily calculate 4 into weight into deficit. It will come out to be 600 ml. Solute fluid deficit, again, we know it will be 400 ml. Total fluid deficit minus 600. And we have to just put a decimal before the last digit. So sodium content in this solute fluid deficit will be 40 milliequivalent. Obviously, there will be no sodium in the free water deficit. It is just plain water. Now, how will you give it? You need to give it because it is 160. You need to correct it over 48 hours. And think which fluid you want to give slowly. It is a free water deficit which is making hypernatremic dehydration unique, right? The solute fluid deficit will be replenished over 24 hours itself. Maintenance you already know how to calculate with Holiday-Segar method. It is a free water deficit component which will be equally distributed in the 48 hours, right? So this is how you calculate, right? So whatever amount of free water deficit you got, say 600 ml in this case, so 300 in first 24 hours, 300 in next 24 hours. Suppose the sodium levels were even higher and you have the free water deficit of 600 ml itself, but you need to give it in 72 hours, then it would come at 200 in first 24 hours, 200 in next 24 hours, and then 200 in next 24 hours, and like so on. And whatever solute fluid deficit, it will be given in first 24 hours itself. So if you calculate all these things, sodium in the maintenance fluid is 3 milliequivalent per kg. So for a 10 kg child, it will come out to be 30 milliequivalent. So you will get 70 milliequivalents of sodium and 1700 ml of fluid to be given in first 24 hours. So what do we mean by 70 milliequivalent in 1700 ml? It means roughly 40 milliequivalents in 1000 ml, right? So the nearest fluid which gives almost similar composition is N by 4 in 5% dextrose. So that's it. This is how you have to write your order for this patient, that N by 4 in 5% dextrose need to be given at 70 ml per hour so as to make a right composition of this fluid. Another method is that sometimes you can give line 1 and line 2 through the line 1 you can give your maintenance fluid, and through the line 2 you can give your deficit correction as calculated by the previous methods, right? So friend, in this technique you need not remember any formula. You just need to get your concepts right. You need to know what is free water deficit, and it is this free water deficit which needs to be given slowly, equally distributed over the duration of the treatment which you have decided depending upon the level of sodium, right? And solute fluid deficit, again, very easy method. You need to know how much sodium you need to add, which just like you add salt, you need to add 1 decimal point before the last digit, and you will also get your sodium component of the solute fluid deficit. So that's it. Thank you for watching.